Continues safe administration of sedation. Dr. Stephen Schaefer pointing out how close the anesthesiologist is, touching the patient, constantly monitoring. Let's watch.
Here. The anesthesiologist is recording all of the blood pressures. Every 5 minutes, the pulse oximetry, the carbon dioxide, the rate that the patient is breathing gets recorded usually every 15 minutes. The heart rate, the heart rhythm. What does the EKG look like? Is being recorded. So all of the drugs are being recorded. This record is not just some static document that gets put in a chart somewhere. It's part of the therapy. You can use it as you're providing the therapy, the anesthesia. You use it to see what happened 10 minutes ago. What was the blood pressure 10 minutes ago, so you can see if it's going up or going down. You use it to keep track of your drugs. When did I give that last dose of something? Here's when I gave it. It is integral to your care of the patient. And if anything ever goes wrong, it's integral so that you and the patient can learn what happened, so that the mistake doesn't get repeated next time, or the complication does not happen next time. Or when the patient is seen by another doctor, the patient can say, here's my medical record, and there was a problem, and the other doctor can know what happened. Keeping this is not a convenience. Keeping this is a fundamental responsibility to the patient. It's also fundamental to the care that is being given. Please continue. So here Dr. Hung is going to observe the breathing. You have to watch very closely because the diaphragm actually is not moving very much when people are sedated. And he then checks the vital signs. And I think if you just continue, I think they're labeled. Yeah, here's the electrocardiogram up here. EKG waveform. This is the pulse oximetry shown here. And finally, this nice regular pattern here is the capnometry. That's the carbon dioxide. Please stop. In this particular patient, young, athletic, the heart rate is only 41. Oxygen saturation is 97%. That means the patient's lungs, the patient's blood is pretty much completely saturated with oxygen, as much as it can carry. End-tidal carbon dioxide here is 42. The normal number is about 40, 42. So that's what you expect to see in a patient who is breathing regularly. That would be the end-tidal carbon dioxide for any of you. In fact, for those of you sitting here, that's about what you would see right now for yourself. That's about what you would see right now for yourself. Most of you would have a heart rate that is probably closer to 70 to 80. Please continue. You check the infusion pump. Please stop. You check the infusion pump because the patient's life depends on the infusion pump giving the amount of drug you specify. Again, you can't say, oh, there's a manufacturing error. The anesthesiologist owns this. They own responsibility for the rate of the infusion and to see that the pump is doing what it's supposed to do. So you check it constantly during the procedure. Please continue. Here he's checking that the pump is giving 100 micrograms per kilogram per minute, a reasonable dose for sedation, maybe a little bit high. Now, here's the saline carrier infusion. Please go back. I don't know if you can go back or not. Stop. Okay, actually go a little bit forward. Stop. This is the bag that I just showed you. Remember I talked about the spike. That's the spike right there. This is the piece of white plastic that is shoved through this. Remember, I pulled this little white tab off and showed you the hole. This is the white plastic that's shoved through that so that this bag of saline infusion will drip into the patient. And you can watch it dripping by seeing the drops right here. You actually can see that it is running. Please continue. And then it comes down, and then back to documentation, just to emphasize, you document, you document, you document, you write down everything. Stop. These little dots here, this is the systolic pressure. Actually that's the heart rate there. He's going to be putting in the diastolic pressure down here. These are coming in every 5 minutes. So every 5 minutes he's writing this down. What was happening during the procedure? This is a responsibility to the patient. This is also part of good care, so if there's a trend, he can see it in his own document. Please continue. Now, let's look at some complications here. Hypotension, please stop. The blood pressure has dropped to 86/38. So the patient's blood pressure is low. How often do we see this in the operating room? All the time. Every day. Propofol lowers blood pressure. And when patients come in and they're a little bit dehydrated because they haven't had anything to eat or drink, and by dehydrated I mean they haven't had saline, they haven't had water or juice or whatever they would have in the morning. When patients come in, they're a little dehydrated, and they get propofol, we see the blood pressure drop all the time. It's no big deal. So he sees the low blood pressure here. Please continue. So there's several ways of addressing this. First, you might give some more saline, but here he's drawing up a drug called ephedrine. Ephedrine is a drug that's simply going to raise the blood pressure a little bit. Please stop. Now, what is this? That's the IV line. Remember, I mentioned the IV is a way of constantly getting drugs, any drug, into the patient quickly. So he pushes this into the IV line, and then this, along with the saline, it flows right into the patient. And as it flows into the patient, it flows into the bloodstream where it works. So he's pushing it into the IV line here. Please continue. Please also notice that this drug was immediately available, and with that, the blood pressure comes back up to 104. Now, stop, let's go a little bit further, and stop here. This is the carbon dioxide. This represents when the patient is exhaling, and there's carbon dioxide seen at the sensor, and then this is the patient inhales, patient exhales, patient inhales, and so on. Wraps around to here. But right here, patient now exhales, and then the carbon dioxide stops. What happened to the carbon dioxide? The airway is obstructed. And when you have this monitor on the patient, you can see that the airway is obstructed immediately. So the airway is obstructed here, and within a matter of seconds, it's clear to the anesthesiologist that the airway is obstructed. Please continue. So this shows up here, obstructed airway. So what happens here is something called chin lift. And just please proceed. And then stop right there. If you pick the chin up and move it like this, so you just pick the chin up and move it forward with your thumb pulling out a little bit, that will almost always open the airway. Anesthesiologists do this routinely. Anesthesiologists do this without even thinking about it. We do it and we don't even change this topic of conversation, because if the person's tongue has fallen back a little bit and the airway is obstructed, you just reach over and you just pick up the chin. And when you do that, most commonly, the tongue is now out of the way and the patient is breathing on their own. Usually that's all that's necessary.